Three, two, one. Recording is on, sir.
So, good evening, everyone. Continuing with the series by Dr. Abha Majumdar, today we are going to listen from her about the newer developments in the management of PCOS in adolescent girls. It's a very relevant topic, and ma'am has really worked hard to make this presentation, importantly for all of us. So, let's listen to her. Please, ma'am.
Hi, good evening, everyone. I hope few people have joined. Have they joined? How many?
There are
How many?
25 participants, including all of us, ma'am.
Oh, great.
I
I'm
think
happy.
people are still
Yeah,
joining.
yeah. And this is very important because, the most important thing is that these PCOS, especially when they have irregular menstruation, they land up with gynecologists. And we have to know how to treat these girls at such a tender age properly so that they don't get traumatized all their lives. So I'm going to talk on the newer developments. First thing is, who are adolescents? WHO defines adolescents as girls between 10 and 19 years of age. So in this age group, body image, sexual identity, and peer interaction are critical for the evolving personality. And if they get burdened with a disease which they do not understand, and people make them afraid, oh, you have PCOS, their whole body image, everything goes for a toss. Apart from association with medical disorders, which this diagnosis has, and irregular menstruation, features of hyperandrogenism in adolescents, they all have substantial impact on self-esteem and cause psychosocial morbidity. These girls shun going socially. They are psychologically very depressed. They don't like to mix with peers in school, colleges. So, timely diagnosis and medical interventions may prevent health sequelae and also contribute to psychological well-being. And that is why they need special attention. I have taken the help of International Evidence-Based Guideline for the Assessment and Management of PCOS Summary 2023. And here all these, you see the logos of Monash University, ASRM, Endocrine Society, ESHRI, CRE PCOS, European Society of Endocrinology. All of them have contributed to this evidence-based guideline for assessment and management of polycystic syndrome. How do we diagnose PCOS in adolescents? We all follow the Rotterdam criteria and we say out of ultrasound diagnosis of PCOS, irregular periods, and hirsutism. Any two are present, it is PCOS, but it is not so for adolescent girls. Here, we need only two things. Both irregular menstrual cycles and hyperandrogenism must be there. Ultrasound is not a diagnostic criteria for adolescents because multicystic ovaries are quite commonly seen in this group of girls who have just started their menarche and the ovaries are still developing. These girls are at risk status for PCOS. Say, suppose you see a girl of 14 years old who's got irregular menstruation and maybe or maybe not any hyperandrogenism. What will you put them? You'll say at risk status for PCOS. You will not diagnose with PCOS. Future reevaluation may be needed if both features persist beyond 3 years post menarche. So menarche started till 3 years, irregular menses was there. And after that, also it is persisting. And with that, if you get hyperandrogenism, then maybe you can start thinking that this is PCOS. All guideline development groups highlighted the need to acknowledge the risk, yet avoid overdiagnosis or premature labeling of PCOS at this age. And this is where I want to stress all of you that please do not tell the girls with irregular menstruation if they are obese or they have a little bit of hirsutism that you have PCOS because the ultrasound says that your ovaries look PCOS. Another important thing is even cycles which appear quite regular, 25 days or 35 days, ovulatory dysfunction can still occur with regular cycles, and therefore we need to confirm that with serum progesterone level. And this is the guideline instruction. For hyperandrogenism in PCOS, Sometimes you don't find overt hyperandrogenism. You very strongly suspect at 16, 17 years that this girl looks PCOS with her menstrual function. Biochemical hyperandrogenism by total and free testosterone estimation is of greatest value in girls with minimal or no clinical signs of hyperandrogenism. So these are important points which I want you to inculcate in your practice when you are diagnosing PCOS in adolescents, and especially if these girls present with irregular periods and do not have overt hyperandrogenism. What is irregular cycles and ovulatory dysfunction? I want you to understand that the first year post-menarche, it is normal to have irregular cycle, very erratic, 2 months, 1.5 months, 3 months, as part of the pubertal transition. After 1 year of menarche to 3 years post-menarche, what are irregular cycles? If they are less than 21 days or more than 45 days. And then after 3 years post-menarche to perimenopause, when we call them irregular, less than 21 is irregular, but then more than 35 days is irregular periods. Or if they have less than 8 cycles per year, then we call them irregular periods. So please be clear, in the first year, however less the periods may be, maybe twice or thrice, do not consider it as irregular. 1 to 3 years, less than 21, more than 45. After 3 years, less than 21, but more than 35 becomes. And 1 year post-menarche, if any time it is more than 90 days and they get a cycle, then we also call it irregular cycle. Now, suppose a girl has primary amenorrhea by the age of 15 or 3 years post breast development. When irregular menstrual cycles present, then we think that it could be PCOS. Like she did not get her periods till 15 years of age, or breast development is there more than 3 years, she's not started her period. And then if she has 1 or 2 menstrual cycles, then generally it is because of underlying PCOS. So for adolescent PCOS who do not meet diagnostic criteria yet and are at risk, reassessment before full reproductive maturity. If the reproductive maturity is at 15 years, 16 years, or 17 years, or 8 years post-menarche is essential to label them as PCOS. This includes those with PCOS features before combined oral contraceptive pill commencement. So we do not start combined contraceptive pills till we have known that yes, they are PCOS and we are giving them for regularization of menstruation. Having said that, what we as health professionals need to know is ensure correct information and education on PCOS at all levels of health professional training to address knowledge gaps. Now, this is a very common thing that girls come to me and say, I had PCOS, I was given some medicines and they said PCOS has become all right. This is a big knowledge gap. We have to tell them PCOS is a genetically imprinted condition. It is going to be there all your life. We can correct the symptoms of PCOS and you can feel absolutely normal, but we cannot cure it. It will always be there underlying, and any factor which precipitates the symptoms will bring it back, will bring back the symptoms. So it is not that PCOS is coming back. PCOS is there, but the symptoms will come back. And therefore, individualized information, tailored information should be provided to all PCOS girls in a respectful and empathic manner. We have to make sure that we tell them very sympathetically. The diversity of population should be considered when adapting practice paradigms. That means somebody where the elders are saying we will not give oral contraceptives, we do not give contraceptives, we don't want to give hormones. Please understand their problems and give them alternative medicines which will cure her condition. And girls should be counseled on the risk of misinformation and guided to evidence-based resources. From there, they can read about their condition. What are common presentation in PCOS adolescents requiring management? Most commonly, we get girls who have menstrual symptoms. like delayed menses, prolonged bleeding, non-cyclical early or late bleeding. These are the commonest 3 symptoms which you get. Hyperandrogenic symptoms, hirsutism, acne, and the typical hyperandrogenic baldness, which is frontal baldness. Weight issues may be there. And the last but not least is psychological symptoms with negative impact on body image. So the initiation of a longitudinal monitoring for whole of life depends on early identification of comorbidities such as diabetes, hypertension, hyperlipidemia. I get girls 15, 16 years who are like 100 kg weight. Already they have acanthosis nigricans. They have hyperlipidemia at risk of diabetes. So it is here where the management has to start. Endometrial cancer later in life. Sorry for this. Management spheres are lifestyle management and weight issues. This is the first thing we need to tell them to do. Along with that, you have to start managing their menstrual symptoms. Here, combined oral contraceptive pills have the first place, metformin number 2, progesterone cyclical or withdrawal number 3, and inositols take the 4th place. Hyperandrogenic symptoms need extreme attention because this is what changes their body image, and they feel very, very let down because of these symptoms, and psychological issues have to be dealt along with. So lifestyle management, I've just devoted one slide. We all understand that lifestyle management is the core focus in PCOS management. There are benefits to healthy lifestyle, even in the absence of weight loss. So just lifestyle, which means a little exercise every day, eating more regulated homemade food, finishing the night meal by 8 o'clock, taking a good 10, 11 hours of gap between the night food meal and the morning first meal, which one takes, exercise alone or diet along with exercise and behavioral strategies should be recommended for all girls with PCOS to improve metabolic health, which means central adiposity and lipid profile. So exercise is very important to do away with the visceral fat. Because of visceral fat, the abdominal girth becomes more. And when the abdominal girth becomes more, even if she's not obese, she loses her feminine structure. And for maintaining and preventing weight gain or modest weight loss. So don't thump on them about weight loss. First, let them have a lifestyle management with just diet and including some type of work into their lifestyle. Don't say that you have to lose 10 kgs or 20 kgs or 5 kgs. If you lose weight, it's good, but at least start exercising, start walking, and diet. For girls who are not overweight in adolescence, the focus should be on healthy lifestyle and prevention of weight gain. So even girls who are not overweight have to exercise because the visceral fat in due course will become more and more. And the weight hip ratio or the abdominal girth will become more. So this is all you have to say. Weight loss should not be their aim. Weight loss should be lifestyle management. What are the menstrual symptoms? We have just spoken. One is delayed menses. Periods don't come for 45 days, 2 months, 3 months. Another one is periods don't stop. And then another one is kabhi bhi aa jate hain. They may come in 20 days, 10 days, or continue to bleed, or I don't get my periods. So what are the 4 medicines which are used? And I will tell you in which condition will you use these. So combined oral contraceptive pill. Just remember this slide. This is very important, and I found it in the guideline, which I thought that I must highlight here. You start combined oral contraceptive pills in adolescence only after clear diagnosis of PCOS to treat hirsutism or irregular menstruation both. No advantage of using high-dose ethinyl estradiol versus low-dose ethinyl estradiol, which is 30 microgram or above, and less than 30 microgram when we are treating hirsutism. So even low dose will be similarly effective vis-a-vis a high-dose ethinyl estradiol. The cyproterone acetate preparations like Diane, Ginit, and all contain 35 microgram of ethinyl estradiol. So they are to be considered as second-line therapy. Why is it so? Because these girls are at metabolic risk profile. We have to think of that. We have to think of venous thromboembolic risk. And you will not imagine, one of my patients had to be carried from the flight on an ambulance because one oral contraceptive pill, and she had a bad venous uh, embolic phenomena and DVT. She had a DVT and she could not walk. She had to be carried in an ambulance to a hospital from the flight. So please do not advise these pills just blindly. Metabolic risk profile is always there for these PCOS girls, and high dose ethnyl estradiol is not good. Plus cost. A Diane tablet will cost 200 to 300 rupees, one of these cyproterone containing preparations, and a normal contraceptive pill will cost 30 to 40 rupees. So when we prescribe a combined oral contraceptive pill, please think about obesity. We are not going to help in their reducing weight if we give a high dose ethnyl estradiol OCP and the cardiovascular risk. Having said that, metformin versus active lifestyle intervention have similar efficacy. So if she can bring in active lifestyle interventions in diet and exercise, metformin, and this is equally efficacious. Metformin does have mild adverse GI side effects, diarrhea, gastritis, and generally it is dose dependent and it is self-limiting also. So if one uses metformin for about a month, generally the GI side effects subside. For those who tend to have GI side effects, we reduce the dose, start with 500 milligrams with weekly or bi-weekly increments. Extended release preparations may minimize side effects and improve adherence also. Maximum daily dose is 2 gram in adolescents. So do not just put them on a homeopathic dose of 500 milligram. If you really feel that you are giving them metformin so that they can have weight reduction, they can maybe also have other effects on menstruation and hirsutism. Safe for long-term use, however, indications for ongoing requirement needs to be considered. Another important thing is that when someone is on long-term use of metformin, vitamin B levels could form. And especially for girls who belong to a vegetarian family or those who are with pure vegan diets. So monitoring of B12 levels and substituting this is important when long-term metformin is given. Now let us see the role of metformin and combined oral contraceptive pill together. Combined oral contraceptive pill is better than metformin for management of hirsutism and irregular menstrual cycle. We all agree that. Metformin could be used over combined oral contraceptive for metabolic indications in PCOS. So if these young girls, parents are diabetic, obese, hyperlipidemic, hypertensive, and these girls are becoming obese and have a poor metabolic profile, it is better to give metformin for that. But then cycle management and hirsutism, combined oral contraceptives are much better. If we give a combination of metformin with combined oral contraceptive pill, then it is most beneficial for everything: hirsutism, irregular cycles, and high metabolic risk group, including those who have a very high BMI, which is 30 kg per meter square. So for a girl who is 5'4", if she weighs more than 85 kg, it is important to give her metformin in the proper dose, which I've told you, 2 grams per day, 2 divided doses as slow release, where oral contraceptive pill is contraindicated. Like you cannot give because there is a history of DVT in the family, or there is something which says that you cannot give a oral contraceptive pill for this girl because she's very obese. Not accepted. A lot of families don't accept contraceptive pills for their children, or not tolerated. She starts vomiting the moment you give her. Then metformin may be considered for irregular menstrual cycles and for hirsutism, but with lesser effect on correcting these disorders. Then comes progestogens. These are either progestogens, which is norethistérone or medroxyprogesterone acetate, or natural progesterone is being used in the West a lot. and progesterone only pills are also there. Now, suppose the girl has irregular long cycles with normal menstrual bleeding. She says, I get my periods every 45 days, 60 days, but they finish in 5 days. What would you give them? But she wants regular menstruation every month. You can give her a progestogen for withdrawal bleeding every 20 to 30 days. If you start from day 20 or 21, she will get her periods in 30, 32 days. If you start on day 30 or 31, she will get her periods in 40 to 45 days. For this, what do we use? Either medroxyprogesterone acetate or norethistierone. The total dose of both the drugs for inducing a proper withdrawal is 100 milligrams divided in 5 days, 10 milligrams BD into 5 days. If there is no withdrawal bleeding after 10 days have elapsed, or maybe 11 days have elapsed of the last dose, what do you think of? Thin endometrium or pregnancy? That means we gave her this when her endometrium was still thin. Thin means 4 to 5 millimeters. She will not get a withdrawal. Or she is pregnant. Any adolescent, don't ever think that pregnancy could not be the reason for her not being able to get her periods. And this is where one may need to use ultrasound in these adolescent girls, that why did she not get a bleed? And you find that the endometrium is thin. So what do you do in these cases where their endometrium is thin? You can give them OC pills. But if she is very obese and you feel that OC pills are contraindicated for her, what do you do? Well, think of it and tell me, what would you want to give her? She still wants regular periods. Her endometrium never grows more than 4 or 5 millimeters. Even after 2 months of amenorrhea, how will you induce a withdrawal bleeding if oral contraceptive pills are contraindicated for her for any reasons? Another situation is one has irregular long cycles, but then when they start bleeding, they have prolonged and heavy menstrual bleeding. For them, what is the treatment? Here you use continuous pill, progestogen or a micronized natural progesterone or progesterone only pill. Any of the three pills have to be used, but you have to use them continuously and cyclically till bleeding amount and duration becomes normal. So if you give them for 3 cycles and the patient tells you that now my bleeding stops in 3, 4 days only, that is the time when her endometrium must have become normal. And you can leave her and see what happens next. So any of the 3 things can be used. A progestogen, norethistierone is more powerful than medroxyprogesterone acetate. If it is micronized natural progesterone, then these young girls do not like vaginal preparations. One will have to give them an oral preparation only. In the West, they use it a lot, but they don't care whether the girl is adolescent. They use vaginal only. And the last is if bleeding, no change. If you find that she's still bleeding after 3 cycles of a progestogen, which we use very commonly, or a progesterone only pill, then the first ultrasound is indicated for these girls to see the endometrial thickness and also a vaginal examination to rule out a submucous fibroid polyp in the uterine cavity or cervix. And I have had a case which I reported, and it was published in the AICOG journal 20 years ago, where a young girl, we couldn't stop her bleeding and an ultrasound didn't show anything. And then we did a EUA and we found a fibroid polyp at the exocervix, which we removed, and her bleeding became all right. So it is important to do ultrasound and maybe also an examination to rule out these conditions, which submucous fibroid, the ultrasound will pick up, but in the cervix, it will not pick up. So we have to do ultrasound for this. Ultrasound, if you do ultrasound, patient is bleeding and you did ultrasound. If it is more than 5 millimeter, please put her on a progestogen or a natural micronized progesterone to revert or prevent endometrial hyperplasia. If her endometrium is less than 5 mm when she's bleeding, then you can regularize her cycles with either MPA withdrawal any day between day 21 and 35. Do not let her go for amenorrheic periods of 2 months and 3 months. Every 21 to 35 days, you have to give her a withdrawal so that before the endometrium builds up a lot on estrogen, it is withdrawn. Low-dose oral contraceptive pill is also a good option for these girls where the endometrium is less for 21 days. So either you use a contraceptive pill, if the family is averse to using that, then you can start her on MPA withdrawal, which is only given for 5 days. So the family doesn't mind that it is just a 5-day pill. But give her the full dose and she will bleed with that. We have to be aware that endometrial hyperplasia occurs by prolonged, unopposed estrogenic stimulation of endometrium. Untreated estrogen excess in PCOS without progesterone exposure is associated with an increased incidence of endometrial cancer. So this is all about this. Inositol, I thought I must cover one slide with this because a lot of us like to use this drug. It is given on an individual preference. Say the patient denies OC pills. Metformin she doesn't tolerate. Then inositol can be given as has limited harm and with potential for improvement in metabolic measures, yet with very limited clinical benefits on ovulation, hirsutism, or weight. So it has very limited clinical benefits on all this, regularization of menstruation, hirsutism, and weight, but it has a potential for improvement in metabolic measures and very little harm. Metformin should be considered over inositol for hirsutism and central adiposity, though metformin has more GI side effects than inositol. Women taking inositol and other, it is considered as complementary or a nutritional therapy. Please understand. So inositol is not a drug recommended by any CDC. They must inform their health professionals that they are on this drug. Specific type of inositol, doses, or combinations of inositol cannot currently be recommended. This is by the guideline development group in adolescents and adults with PCOS due to lack of quality evidence. There is this is the most important thing that they do not recommend inositol currently for adolescents and adults, but one can give them on individual preference. Having said that, hirsutism. What are the pharmacological interventions we can do for hirsutism? Combined oral contraceptive pills, anti-androgens, and topical therapy. Cosmetic measures, you all know. Direct hair removal methods, you all know, laser, electrolysis, waxing, shaving, plucking. So let us go on the pharmacological interventions. Combined oral contraceptive pill. Now, this is a COG committee opinion 2019, where they have written that treatment of acne and hirsutism should not be withheld during ongoing longitudinal evaluation for at-risk PCOS. So you've not labeled your patient as PCOS, but she has hirsutism. You must start treating her for acne and hirsutism because it spoils her body image at a very tender age when she's 14, 15, 16 amongst her peers. However, hormonal therapy should not be started before menarche. They've written this, which I don't understand. After menarche only, even if she comes at 11, 12, 13 years with a lot of acne, no hormonal therapy. She's not started her periods yet. Now, if she is getting hormonal therapy, a combined oral contraceptive pill, and the response is suboptimal after 6 months, then additional hair removal therapies and anti-androgens can be added. For moderate to severe hirsutism, hormonal therapy and anti-androgen can be started concomitantly. So I'll come to this, that what is hormonal therapy and anti-androgen. Any estrogen-containing therapy should be more effective at reducing acne, particularly for adolescents with premenstrual acne flare-up. So OCPs are very good for acne flare-up, but for hirsutism, you can use hormonal therapy or anti-androgens directly, concomitantly. Anti-androgens, which are the anti-androgens which we use? If 6 months of combined oral contraceptive pills with cosmetic therapy, or there is contraindication for combined oral contraceptive pills, or they are poorly tolerated, then anti-androgens have to be used. Spironolactone can be used in the doses of 25 to 100 milligram a day, or even up to 200 milligram a day, has lower risk of adverse effects. Cyproterine acetate and drospirenone used as OCPs. They are available as OCPs in our country, but outside they are also available as 10 and 12.5 milligram tablets. Finasteride has an increased risk of liver toxicity. Dose is 5 milligrams a day, and flutamide is not used because it has a risk of severe liver toxicity, even though the dose I've written here. But it is the first 3 drugs which are used. The second drug is generally used as a combination pill with ethyl estradiol, but the dose is quite high in ethyl estradiol. And that is why acne tend to flare up when you stop these drugs, because high dose of ethyl estradiol suppresses the acne. Once you stop, there is a big flare on this. Drosperinone, cyproterine acetate, and spironolactone. Now, drosperinone is structurally related to spironolactone. So, drosperinone and spironolactone are from the same group of medicine, and 25 milligram of equivalent to 25 milligram of spironolactone, which we use here. 3 milligram is equivalent to 25 milligram, and available as Yasmin, Yamini, Dronis 30, Chrysanta. And then there is one as Yaz, which has ethyl estradiol only as 20 microgram. So you can find this and prescribe this if you want to use it as the first line OC pill for hyperandrogenic symptoms. Cyproterine acetate everywhere, either higher dose of 12.5 to 100 milligram is recommended, but nobody uses it. 2 milligram is there in combined OC pills, and all these have 35 microgram of ethyl estradiol. So cyproterone acetate combinations have high doses of ethyl estradiol, whereas drosperinone also has the low dose one, which is available by the name of Yaz. And spironolactone, it is not taken as a OCP, can be used in combination of OCP. Dose can be 50 to 200 milligrams. Side effects are hyperkalemia, irregular menses. I mean, it doesn't treat irregular menses. This is what you have to remember. So for irregular menses, you will have to give a progesterone withdrawal, or you will have to give OC pills, but you can use spironolactone non-stop for them. One slide on topical eflornithine. This is a cream which is FDA approved, irreversible inhibitor of ornithine decarboxylase enzyme, which is essential for hair growth. It is used as monotherapy for mild cases of facial hirsutism or with other therapies. Effect is seen in 4 to 8 weeks. So it takes about 1 to 2 months to see the effect, and reversal of hair growth will happen if you discontinue within 8 weeks. Dose is BD application. At least it has to be 8 hours apart. So you cannot apply in the morning and afternoon. You have to apply morning and night. Trade name is eFlora, Hinder, Ellen, and Veniqua. In India, it is mostly available by the name of eFlora, or I think Veniqua. So mechanical laser light therapies for hair reduction, I will not highlight this much. I only want you to understand one, that mechanical laser and light therapies not only reduces facial hirsutism, but it is therapeutic for depression, anxiety, and quality of life. So it is very important for few girls to be referred for this, because of hirsutism, they feel very depressed, and they feel they are different from other girls. In PCOS, naturally, more sessions are required compared to idiopathic hirsutism. Consider following when laser is prescribed. Wavelength and delivery of laser treatment varies by skin and hair color. Laser is relatively ineffective in women with blonde, gray, or white hair. So in the white women, Caucasians, it is less effective. In us, it is more effective. The addition of oral contraceptive pill with or without anti-androgens to laser treatment may provide greater hair reduction and maintenance compared to laser alone. So you can give a combined oral contraceptive with or without anti-androgen. Mechanical hair removal with intense pulse light could be considered. Benefits may be less pronounced compared to laser treatment. No evidence to support efficacy of home-based IPL kits where they just have this light to expose and burn all their follicles. So management of hirsutism in a nutshell is multimodal therapy is most effective approach to treatment of. This includes lifestyle changes and androgen suppression or blockade, which medication that slows or prevents new hair growth. Hormonal therapy not to be started before menarche, and once you start it, may take 6 months before benefit is seen. This is again from the guideline of ACOG 2019. Normally, the guideline, which is the new guideline, says that you will start hormonal therapy only once the diagnosis of PCOS is established, 3 years after menarche. Any estrogen-containing therapy should be effective at reducing acne. So acne, the most important thing is estrogen-containing therapy. So OC pills which have estrogen, higher dose is better, but higher dose is bad for the metabolic side effects of PCOS. And those who report premenstrual acne flare-ups, OCPs are very effective. Patients should be assessed at routine intervals every 3 to 6 months. What I tell them to take a selfie very close to see all the areas where they have hirsutism, and then take a selfie again after 3 or 6 months. And also look for adverse effects and response to treatment under they are stable. Then they can be monitored annually. Monitoring of serum androgens is not recommended. If they don't have hirsutism, even if they are labeled as PCOS because of the irregular menstruation and because of biochemical rise of testosterone and total testosterone, please do not monitor them with androgen levels. Yes, once they have reached complete maturation, 16, 17 years, you can do ultrasound to sort of reinforce your diagnosis of PCOS in these girls. So psychological therapy, antidepressants, and anxiolytic treatment is to be, psychological therapy should be considered first-line management. Be kind to them, be considerate to them. Don't say you have to lose weight, you are very obese. This is, you have to, I mean, don't put that pressure on these girls. They will run away. They will never come back to you. And antidepressant medication should only be second line, preferably only in adults, not in young adolescents. And lifestyle intervention and therapies for hirsutism and acne improves psychological symptoms. And when you manage anxiety and depression, then they adhere to the PCOS treatment management much more easily. Having said that, this is the ACOG recommendations for adolescent PCOS. Hirsutism and acne should be taken seriously because of the effect on self-esteem and quality of life and potential for psychosocial morbidity. No clear consensus guideline on the diagnostic criteria for PCOS in adolescent girls within 2 years of menarche. I would say within 3 years of menarche. Thus, gynecologists should exercise caution in assigning this diagnosis prematurely. Treatment of acne and hirsutism should not be withheld during the ongoing longitudinal evaluation for possible diagnosis confirmation of PCOS. Finding of polycystic ovarian morphology and ultrasound has a prevalence in adolescent girls in 40%. And it is not predictive of the presence of future development of PCOS. So please do not resort to this diagnosis. Pelvic ultrasonography is not routinely indicated unless serum androgen levels or the degree of virilization is concerning for an ovarian tumor. Having said that, follow up on PCOS. When a girl comes at 18 years old to me and I have established the diagnosis of PCOS, I tell her, keep a weighing machine in your house, in the bathroom, see your weight once a week, because once your weight goes up by 4 or 5 kgs, it would be difficult to bring it back. But if it goes up by 1 kg, you can cut down the weight and bring it back. Ensure menses at least every 40 to 45 days so that she gets more than 8 periods a year. OGTT should be done yearly, not just a fasting glucose. Blood pressure should be seen yearly, especially those who have a history of metabolic syndrome in their family. Lipid profile yearly. So this is all I have about PCOS, where we diagnose it at an early age. This is how I follow up my cases. And I have brought to you my regime, as well as I have brought to you evidence, which is latest from 2023 and some evidence from other societies in 2019 and 2021. So this is all about today. Adolescents have a long way to go, and wrong diagnosis can make a path difficult. So don't put a diagnosis, just say we'll watch your irregular menses, we'll see, we will treat them. And you can give just progestogen only pill. You can give her a withdrawal bleed and see what is good. Now, the life lesson for today is one. I finished with my talk and I said I will put a life lesson: masterly inactivity and timely intervention. What is masterly inactivity? A patient is bleeding. You are tempting to open her up postpartum. She's having PPH. You are tempted to open her up post delivery, and you think, no, this bleeding is not stopping. It is 5, 6 hours. Her hemoglobin is falling. So So be sure what are you heading into. Suppose she had a history that everything is adherent inside, and with great difficulty, the cesarean was done and the baby was pulled out because the anterior surface of the uterus was clear. Getting into her abdomen would be much more difficult, but waiting and maybe giving her mm, a embolization of the uterine should be much better, which once upon a time in my own practice, I used to do a open internal ligation. Now it can be done very easily with embolization, and hence it is best to do timely intervention before she goes into irreversible shock. But masterly inactivity is very important, that you open up the abdomen and then you don't know how to get the uterus out and how to stop the bleeding. And hours go by and you reach the patient into irreversible condition. This is just one example I've given. But when there is inactivity, it should be very masterly monitored. You should know that you are watching every second of the patient. Life is precious. And timely intervention and correct intervention is very important in life, especially for us doctors. Thank you very much.
Thank you, Dr.
I
Abha. That was like a very, very comprehensive talk on management of adolescent PCOS. And I'm sure everybody here who have listened would agree that things that you've said today are not in the books. And everybody, I'm sure, has clicked pictures of each and every slide that you have worked upon. And thank you very much for taking so much effort. I'm a witness to how much effort Dr. Abha takes each time to make these presentations. And this presentation would stay with us for life. And this is something Dr. Abha has gifted to all of us. Um, so coming to the questions, ma'am, I had few questions myself before I start with the chat. So, ma'am, there is something called a term which we don't see in the books or in the guidelines. It's called as lean PCOS. So, what is, because we come across a lot of girls who are not overweight, they are within the range of BMI, but still they have these symptoms of PCOS. So, what do you think would be different about managing these girls?
So do they have hirsutism? Why have they come to you? Irregular periods?
Yeah, irregular periods and facial hair and acne.
Okay,
So
right.
yes,
So see
hyperandrogenism.
how bad is the facial hair, whether a local cream will help, and how bad are her irregular periods. So if she is lean, but she is a PCOS and her family history has diabetes, hypertension, or metabolic syndrome in the family, then please use simple oral contraceptive pills. Don't go on to cyproterone acetate containing ones. One is to regularize her periods, right? She's a thin girl
Correct.
and she's not overweight, so you don't need to give her metformin, but lifestyle management, which means that every PCOS girl has to be advised about a little exercise, a little walk, or a little game activity, a swim, just half an hour to 40 minutes, 5 days a week. That will change a lot of things for her. Plus, in her diet, most working girls, these are studying girls, generally adolescents. So not to go on binge eating of chips, chicken, chow mein. I see all the C's. So, which is which girls are very fond of. So they can have junk maybe once a week, but rest of the days they must have a regulated meal plan. Young girls, it's not easy, but yes, they can try. They can have junk sometimes, but not always. So for a lean PCOS, the main and irregular menses and hirsutism, oral contraceptive pills will do very well if they've reached a pakka diagnosis that yes, it is PCOS underlying, but not the cyproterone acetate pills, which have a high dose of ethinyl estradiol, if there is family history of metabolic syndrome, right?
Right, ma'am. Coming to the questions, Dr. Shabnam Tahir wanted to know what is your experience regarding metformin associated lactic acidosis, and do we need to do LFT, KFT on a patient who's on metformin 1 gram twice a day?
Shabnam, I
And
think
also,
brought in
do
a very
we need
important
an
thing.
extension to that question, ma'am? Sorry, is
Yeah.
also, do we need to supplement B12 in the patients who are on metformin for a long time?
See, Shabnam, this is a relevant question, but lactic acidosis is not very common with metformin. People use it for years. And LFT and kidney function test are not important because it is not liver toxic. toxic. It is not kidney toxic. So the only thing you may keep your mind is to maybe lactic acidosis. Another thing is B12 supplementation is a good supplementation after few months, but you can always monitor B12. You can, after 6 months or 1 year of metformin, just see the B12 levels. If they are going down and the person is a vegetarian, not even a vegetarian, a vegan, then you need to monitor B12 levels. Otherwise, we get enough B12 from our food, dairy, which we eat on a routine basis. So don't increase the cost and the medicines for this young girl by giving her an additional tablet of B12. Lactic acidosis happens in people who are already with metabolic syndrome, who are already suffering with symptoms of metabolic syndrome. In young adolescents, 2, 3 years of metformin should not even raise the question of lactic acidosis. All right?
Dr. Shabnam, do you want, I hope your question is answered. Ma'am, extension to this was also another question related to metformin, is that if we have started metformin, how long do we continue giving it?
This guideline says that you can give it quite long depending on what her profile is. But I think that, one must be very careful in starting metformin because there is no end to giving metformin. But if she's really obese then and has a family history of a metabolic profile and she herself has become overweight, blood pressure may still be normal in adolescence, but it will start growing up. So in these girls, metformin is important. Where extreme central obesity is there, she's already plus 28 BMI. I think metformin is for those girls, or they do not tolerate OCPs.
Right, ma'am. So now coming to the question that you had asked about having a thin endometrium in PCOS girls and the OC pills is contraindicated. So I think the first answer was OC pills and estradiol valerate. But I
Right.
think when both of these are contraindicated for these girls,
Yeah, OC pills are
what is
generally
the...
contraindicated because of the ethinyl estradiol they have, right?
Yes,
So
so same thing for it's estradiol valerate.
yeah,
So
that's more micronized natural estrogen. So, I mean, I just thought that letrozole is given to post-breast cancer girls, women who have estrogen receptor sensitive tumors. So I just thought if I give her letrozole, clomiphene we cannot give for a long time. If I give her letrozole and I can induce her ovulation every month, she will get her periods, estrogen will be low. So I just started giving a few girls who did not want to take oral contraceptive pills because of the side effects and who did not get a withdrawal with Meprate even after 3 months because they...
just like we give it for ovulation induction in
Yeah, but then
patients who
someone
want to
brought in
conceive.
a question. Shweta just told me, ki, ma'am, will inducing a ovulation every month, is it okay with letrozole? Because when it is given in breast cancer, then it is given as a continuous tablet, over
Continuous.
years to keep the estrogen low. But if every month her ovulation is induced, but in letrozole, I've seen before ovulation, estradiol levels are hardly 60, 65, 70. We are not taking her estrogen levels high. Conversely, if we give her this medicine, Progenova, something like estradiol valerate, we will be increasing her estradiol levels much higher,
Much higher.
right? So I think this should be a good idea, but nobody has embarked on it. Nobody has written about it. This is just my lateral thinking. So please do not take it as a confirmed medication, or uh, don't say it in your exam, but practically I have used. Tejashree knows that I've given it to 2 patients
Yes.
and they get
Yeah, it works
absolutely
really
good
well.
menstruation in 30, 35 days. We did a serum progesterone, she ovulated and she was very happy.
Yeah. Ma'am, Manisha, Dr. Manisha wants to know that what is the reason for thin
Another thing
endometrium?
which we can do for thin endometrium is give them maybe a dermal estradiol and then induce bleeding with progesterone withdrawal. We'll have to see whether the endometrium grows with dermal estradiol or not, because these are PCOS where the endometrium is not very responsive to whatever unopposed estrogen they have. And these PCOS are less likely to develop endometrial cancer later in life, but then they don't have a withdrawal. So, I mean, we have so many options open and we have so many questions here to
I
what.
think our fellows are allowed to answer only in the end.
No, they can answer.
Tanu,
No, Acha,
yeah,
Tanu has written letrozole. No good. Because she's seen me giving. I had no
same
answer
here.
for this girl who said, I cannot take oral contraceptive pill. And withdrawal doesn't happen to her because her endometrium remains thin. So I just thought of it and I discussed with all my fellows that it should be safe. And I gave her, and she started menstruating every month. That's why Tanu has answered. But this is not in the books as yet. So maybe
Ma'am,
in few
Dr.
years.
Pratyusha wants to know that do we need to test biochemical hyperandrogenemia in all
No,
without clinical hyperandrogenism or hirsutism? Do we
no,
need
it is
to do a
only
biochemical?
only in adolescence, Pratyusha, because here you're trying to make a diagnosis of PCOS and there is no clinical hyperandrogenism. But after 3 years, also her periods are grossly irregular. They come after 45 days. So here, after 3 years of menarche, you can do a total and free testosterone. And if it is high, you can start putting this at risk for PCOS to probably a PCOS, but you can do a longitudinal evaluation for as long as 8 years to establish the diagnosis. Okay.
Ma'am, Dr. Manisha is asking,
What is
what
the
is the
reason?
reason for thin endometrium despite a high
High.
estrogen level?
They're not high estrogen levels. One, you will find that they are just like 60, 70 picograms. The endometrium somehow does not respond, I would say. See, all PCOS with unopposed estrogen action does not grow into hyperplasia and does not have prolonged bleeding. So some PCOS have hyperplasia very fast, they have endometrial polyps very fast. So every endometrium is responsive in a different way to these equal levels of estrogen. What I feel is that these girls who have thin endometrium, the estrogens are maybe 60, 70 baseline, but that does not induce hyperplasia in them because it is less responsive. That is all. I have no other explanation. If you can find an explanation, please let me know.
Ma'am, Dr. Renu wants to know that once we stop the OC pills, many of the patients have return of their symptoms in the form of irregular cycles. So how
Renu, I
long do
think,
we
yeah, I think you were
give the
not there in the
OC pills?
initial part. PCOS, once is there, will always remain all their lives. So if she was a lean PCO and had irregular period, even reducing her weight will not bring her back. But if she has gained weight and then her periods became irregular, then maybe reducing her weight might bring her periods to regular. But whenever you stop OC pills, she will always return to irregular cycles. So please do not tell them that taking OC pills for 1 or 2 years will cure you. Whenever you stop the treatment, the symptoms may return. Our main thing is the treatment is not curative, it is only corrective. We only correct the symptoms. We can't cure the underlying PCOS. Shabnam, thank you for the God bless you. I'm so glad to read this.
Thank you so much, ma'am. I think each one of us can't thank you enough. And please accept our sincere gratitude for taking all the efforts each time for each and every lecture. Thank you so
Thank you
much.
everyone for joining me, and at least um, you make my effort worthwhile by listening and putting in questions. But masterly inactivity and timely intervention is a line which I heard 30 years ago, and it stuck to my mind. You know, as doctors, we need to really practice this. Please remember this whenever you are in a hurry to do something, that maybe waiting will help. Okay. Good night.
Thank you so much, ma'am. Always a pleasure. Thank you, ma'am.
Thank you, Tejashri.
Bye.
Thank
Good
you.
night.
Where is my whole team? I need to thank all of you.
Dr. Vishal.
Yeah, I can see Sumati. Very good to see you, Sumati Saxena. Vishal Dave, thank you so much.
Thank
All
you,
the
ma'am.
support team,
Welcome.
thank you. And let's hope that we get the YouTube version and I can put it in the site. Okay.
Yes, ma'am.
Good night.
Thank you so much.
Good
Thank
night,
you.
ma'am.
Okay. Bye, Tejashri.
Good night.
Good night.